Dr. Jimenez, and we are here in Georgia Chiropractic Neurology Center. Today we're going to be talking about one of the most common causes of vertigo, BPPV. Here in Georgia Chiropractic Neurology Center, we have been helping patients since 1981. We are 7 doctors. The clinic director, who is Dr. Ellis, is the founder of Georgia Chiropractic Neurology Center. We see patients from TBI, vertigo, anxiety, depression, dysautonomia. We all have our own specialties and subspecialties, but we all do brain-based care. A little bit about me. I am a lead clinician here at GCNC. I am a chiropractic neurologist, so I have a chiropractic degree, and I have a diplomate of the American Chiropractic Neurology Board. I also specialize in vestibular rehabilitation, so I did my fellowship from the American Board of Vestibular Rehabilitation. Is one of my passions, so we're here talking about vertigo and dizziness. And I also have the pleasure of being one of the adjunct professor at Life University in the Chiropractic Science Department. So we have been doing multiple talks here in GCNC through the past month and in the future month, and our purpose is to educate our patients in understanding the different conditions, the symptoms, the causes, diagnosis, and the different treatment options that we have for you. And today we're going to be focusing mainly on what we said it was BPPV. So let's start. BPPV stands for Benign Paroxysmal Positional Vertigo. Benign means that it's not a life-threatening condition, so it doesn't cause any further illness. Paroxysmal means that it is sudden, so the vertigo can come and go, or is very brief. Positional means that the vertigo can be caused by any changes in position. It can be head positions when you bend forward, when you lay on your back, or when you roll into your side. And vertigo, which means false sensation of spinning or rotation, or just moving when you feel the room is rotating around you, or when you are rotating in relation to the body. So that is vertigo. BPPV is actually one of the most common inner ear disorders. As we said, it causes intense dizziness, or specifically vertigo, and is triggered by head movement. When people go to different medical doctors or the hospitals with dizziness or vertigo, 20% of those people are diagnosed with BPPV. It's most commonly in elderly women, mostly above 60, 65 years old, and it has a very high recurrence after you have your first episode of BPPV. Around 15 or 20% of our patients, or not our patients, but most of the patients get what we consider a second episode of BPPV after experiencing the first episode of vertigo. Some causes and risk factors for BPPV are head traumas. We see a lot of people with traumatic brain injuries or concussions. Our first thing to rule out after they come with concussion or history of concussions and vertigo is BPPV, because this is one of the main risk factors. Another one or cause is prolonged recumbent position. I had a patient one time that she was having a massage, and after getting up from the massage, she started having a vertigo effects, and that lasted for a couple of days. And then when she came the next day to our office, I assessed her for BPPV, and she was actually positive for it. Other causes can be vestibular neuritis, Meniere's, or labyrinthitis. Any inner ear disorder can be also a cause of BPPV. We also know osteoporosis, hypertension, even vitamin D deficiencies can be risk factors for having BPPV. And there's a lot of research that even like dehydration can be one of the causes for it. What symptoms our patients experience when they're having this condition? According to research, one of the most well-known symptom is the loss of balance. But the most common symptom that I see in the clinic is the sensation of rotation when they change positions. This is one of the main when we're doing the history and the patient is with us in the physical examination. When the patient says, I roll into my bed or I go on my back and then suddenly I start having this sensation of rotation that lasts for a couple of seconds to a couple minutes, that can means that you might have some sort of BPPV. Other symptoms can be trouble walking, lightheadedness, nausea, vomiting, mainly when they change the position. I have a patient right now that she described it as queasy, and even some patients, but it's less common to have blurry vision. So as we said, BPPV presents as a brief episode of vertigo. Sometimes, or depending on the research, it can last between 30 seconds or 2 minutes. Depending on the position that they are in is how long the vertigo can last, or the location of the BPPV as well. Common triggers, we said about the head positions. It can be rolling over the bed, looking up or down, raising from supine position, which is laying down and then stand or seating, or laying down to standing up, or even leaning forward. It's very important for us when we are doing the physical examination here, we check vitals because some people get dizzy or what they call vertigo when they change positions from laying to standing. But most of the times, there can be a lot of causes for these different symptoms. So we need to rule out any problems with heart rate or blood pressures when they change positions. So we need to rule out dysautonomias or things like that. But it's very common for people with BPPV to have this sensation also when they do that change in position. Before we go into the pathophysiology, I want to talk about the anatomy of the inner ear. So we have heard the term of vestibular system. We have two types of vestibular system, or two parts. You have the peripheral versus the central peripheral system. As part of your peripheral vestibular system, you have something that is called the inner ear. And we all have seen our ear. You also know that you have an inner canal, you have your middle ear, and you have your inner ear. Your inner ear has 5, what we call characters, 5 components. We have 3 semicircular canals, which if you see here, you have the 3 semicircular canals. You have an anterior, you have a posterior, and you have a horizontal. They sense angular acceleration, or they sense all the information that comes from your head when you turn your head to the right, when you turn your head to the left, forward, backwards, and it tells your brain that you're moving your head. We also have 2 other components that are called the otoliths. The otoliths sense mainly gravity, or when we are translating. So these are what we use when we are in the car, when we're translating forward, backwards. When we are in an elevator, we're using these components of the inner ear. And the 5 of them are always sending information to your central vestibular system and telling you where you are in space, okay? If you see in here in this picture, you have the 3 arrows. They are pointing into your 3 semicircular canals. And they have inside some liquid that we call endolymph, okay? So when you move the head side to side or forward and backwards, that liquid moves inside the canal and sends information into your brain telling that you're moving your head. In the next slide, I'm pointing into your otoliths, or your saccule and your utricle, which we already said that it sends translation either forward, backward, side to side, or up and down. Now, I added a picture on the right, and here you're going to see what we call the otoliths. if you see on top of the where the arrow is pointing, you can see some what we call crystals. What you're listening to when you hear people saying, "Oh, I have crystals on my canals," those are the structures that they are referring to. They're called otoconia. There are calcium carbonate structures. What happens is those crystals on top of that gel-like structure on the otoliths, they get detached. Let's say that you hit your head and they get detached, and they then later move into the semicircular canal. It can be positioned on the canal itself, or sometimes in what one of my colleagues said, the switch. So it can be in different parts of your semicircular canals and can cause different type of BPPV. So we have different prevalence depending on the canal of where the crystal it is. It is more prevalent to have BPPV on your posterior canal. It counts for 75 or 90% of prevalence. Most of the people that have BPPV on this canal, they are going to tell you that the vertigo happens when they tilt the head backwards or when they lay on their back. When people or patients tell you that they have vertigo or they have sensation of dizziness or rotation when they are rolling into bed, then you think probably that the BPPV it's mainly on the horizontal canal. And that accounts for 10 or 20% of this prevalence. The anterior canal, which is the less common, this one can cause symptoms when you are bending your head forward or when you are changing your positions from laying to standing. And this accounts for a prevalence of 1 to 5%. So most commonly, and the one that we see the most, it's the posterior canal BPPV. In other occasions, you can have mixed canals, so that make it a little bit more complicated to treat. So how we diagnose it? There's a diagnostic criteria for BPPV. It includes a recurring attack of positional vertigo or dizziness when you change positions. But at the same time, it has a characteristic of positional nystagmus. And nystagmus is what we call when some people say that the eyes are moving very fast or they're having like flutters. It's mainly when you have what we call a slow drift, so the eye moves very slow and then a fast phase to the opposite side. If you see the pictures on the PowerPoint, you can see the slow phase and the fast phase. And you can have different type of nystagmus depending on the type of BPPV that you have. So you can have either vertical, so up beating nystagmus with torsion. You can have down beating nystagmus with torsion. You can have purely side to the right, purely to the left. Depending on the type of nystagmus is the type of presentation that you're going to, the type of BPPV is the type of presentation that you're going to have. There are two positional maneuvers that we do here, or the most common that we use to diagnose BPPV. Mainly, we do the Dix-Hallpine maneuver to test for posterior or anterior canal BPPV. And we also do the supine head roll test to diagnose horizontal BPPV. There's other maneuvers that you can perform to get this diagnosis, but these ones are the most common that we use here at the office. To treat the BPPV, the gold standard is a reposition maneuver. Depending on the location of the crystals and the canal that the crystals are located, is the repositioning maneuver that you're going to perform to your patient. So most of our patients, research-wise, they say that 80% of the patients, the BPPV can go with just one reposition maneuver. In my experience, I find that 2 or 3, it takes me 2 or 3 repositioning maneuvers to get rid of the BPPV. So it actually is 92% with a repetition according to research. If you do have posterior canal BPPV, we do something that is called the Apley maneuver. It's a specific maneuver to get rid of the crystals, specifically on the posterior canal. Or we can also do the cement maneuver. Most of the time, sometimes you can send those at home exercises, or we can perform this in here. We can perform them here at the clinic. For horizontal canal BPPV, sometimes we use, most of the time, actually the barbecue roll, or the Guffanis maneuver is another one very well known to get rid of the crystals in the horizontal canal. And in the anterior canal BPPV, we tend to use more what we call the reverse Apley. So it depends on where is the crystal in the different canals is the treatment that we are going to perform. So it's not safe to just say, okay, I have vertigo. When I change positions, I'm gonna go to YouTube and do one of the reposition maneuver, because you don't know where is the location of the crystal, so you can make things worse if you pick the wrong one. Here you can see an example of the Apley maneuver, or how it looks like. For this one, which is one of the most simple ones, is you sit on the bed, you turn your head to the right. Let's say that you have a right posterior canal BPPV. You turn your head to the right 45 degrees, and then you bring your head back. Most of the times we do this either with eyes closed, or we use some infrared cameras to see your eyes, to see if you have the nystagmus, when that goes away. Or sometimes we also take your symptomatology. So you turn your head to the 45 degrees, you close your eyes, and then you go back. And you stay there for, let's say, 30 seconds, 45 seconds, a minute, depends on the patient, until the nystagmus goes away, or until the nausea or the dizziness or the vertigo goes away. And then you continue turning the head to the opposite side. Again, we wait until the nystagmus goes away or until the symptomatology goes away. And then we continue rolling the patient to the side, and then we finish sitting up again. So it's a very simple maneuver, but we need to make sure that we pick the correct one, and then we do it the right amount of times. Self-care and prevention tips. So things that you can do when you know that you have BPPV are, you tend to move a little bit more slow when changing positions, so you don't get that sudden symptoms of vertigo. Most of the time, we tell the patient to don't sleep flat, because that can cause most increase of the symptoms. Maybe sleep with your head a little bit more elevated. I like to use the recliners. Stay hydrated. As I said before, a lot of the research said that hydration can also cause some of the BPPV. So staying hydrated is also very important, as well as a balanced diet. If we decide to give you home exercises, then perform the exercises that were recommended. And if the symptom persists, then call the clinic, and then we can continue with the treatment until we're able to help you. What to expect after the treatment? Most of my patients, they are very scared when they come here with BPPV because they have vertigo. They're scared to roll into the side. They have anxiety. There's something that we see in a lot of the patients with BPPV, because they feel that they're gonna vomit, or they have a lot of nausea. So we need to tell them what to expect after we do the treatment. So it's normal, it's common to have some sort of sensation of dizziness or unsteadiness after we do the maneuver. I have seen it in a lot of my patients, and then after the visit, they feel super good. So it's until the brain is able to adapt. Avoid sudden head movements for 24 to 48 hours. Some research suggests that. And I tell to my patients, just like look straight, don't move your head, don't shake your head, don't say no to anything. And then follow up again if you need or if you continue having your symptoms. So don't worry if you still having a little bit of a dizziness after the treatment. It's common. It takes a little bit for your brain to adapt. Now, what happens, and this is the most important slide, I think, if the BPPV is left untreated? So we talk about having your peripheral versus your central vestibular system. We said that the inner ear is part of your peripheral vestibular system. Your central vestibular system is in your brainstem, and that sends the information or receive information from your eyes, from your inner ear, and from your feet. It also receives information from your neck, from your jaw, integrates all the information, and tells your brain where you are in space. What happens is, if some of my patients, they have had chronic BPPV for a couple of months, or it comes and goes, or is left untreated for a lot of months, they start developing other symptoms. Some of the things that we see is what we call vestibular maladaptations or compensations, which causes for the brain to receive abnormal signals from the inner ear. This causes what we call a negative neurofeedback, causing chronic dizziness. Okay? When I told you that the central vestibular system receives the information from your eyes, from your inner ear, and from your feet, that means that it matches the information that comes from the three systems. If the information that is coming from your inner ear is wrong for a long period of time, there's going to be something that is going to be developed, and it's called sensory mismatch. So your brain, instead of using your inner ear, your vision, and the information that's coming from your muscles and your joints, it's going to rely mainly on your visual system and your proprioceptive system, which is the information that's coming from your joints and your muscles. Okay? This is going to cause risk for falls. It's going to cause a lot of postural instability, which is going to cause a lot of cascades of other symptoms because of that. As I said, most of the people with dizziness and vertigo, or actually, according to research, 30% of the patients that have vertigo or dizziness have anxiety. So they can develop autonomic dysfunctions also. It can develop headaches if you have chronic dizziness for a long time. And it can also develop what we call motion intolerance. So these are the people that cannot be on the car, on the passenger, or sometimes when they go to the stores, they are very overstimulated. Or if you go to a boat, you feel nauseated. So they start developing motion intolerance. Your brain and your cognition is also integrated on your vestibular system. So you can start developing symptoms like brain fog, poor concentration, not knowing where it's centered, like spatial awareness. So that is something that can be caused by a central vestibular disorder, which can be caused by an untreated BPPV. Long-term motor consequences, which is the ones that we see the most in chiropractic offices, are cervical tension or secondary musculoskeletal issues. If you continue having all these issues, you can start having abnormal gait patterns, problems with falling. So, or you can start having like compensations where you start having a lot of cervical pain because of it. So you want to get that if you're experiencing vertigo, if you're experiencing dizziness, you really want to get to the root of the vertigo, because you don't know if it's something that is super simple and it can become something super more chronic, which can cause you to have a lot of imbalances, which can cause you to have more symptoms that you had at the beginning. So That is my presentation for today. If you have any of the symptoms, or if you think you have BPPV, or if you have any history of traumatic brain injuries or vertigo, dysautonomia, or if you know somebody that can benefit from our care, you can call the office for a free consultation. And here's our phone number, 770-664-4288, and our email. Thank you.